All right. Well, welcome everyone. This is our fourth and final Coffee and Conversations for 2025. And so welcome. We're excited to have you join us for this. We are lucky today to actually have two speakers. And so we have a recent Doctor of Nursing Practice graduate, Dr. Judith Noameshie, who is also a family nurse practitioner and will be speaking a little bit about the work that she did for her DNP project in collaboration with her mentor from Ghana. And so also joining us is Dr. Abigail Kusi Amponsah from Kwame Nkrumah University of Science and Technology in Kumasi, Ghana. And Dr. Abigail served as the in-country mentor for Judith's project, and has actually helped support a few of our students related to the topic of pain management for individuals who have sickle cell disease. She's had a particular interest in kind of emerging adults, young adults, and using cognitive behavioral therapy for pain management. So Judith and Abigail will be presenting today on this topic. I do want to note that we had a student named Esther who started this work a couple of years ago, exploring whether or not cognitive behavioral therapy was kind of feasible and acceptable to young adults for pain management. And then Judith was able to carry on that work in collaboration with Dr. Abigail, looking at a training for nurses at the hospital to continue this work. So thank you, Dr. Judith and Dr. Abigail, for joining us this morning, and I am going to turn it over to you, and then we will have time for questions and conversation at the end of the session as well.
Thank you very much, Michelle, for the kind introduction. And I do hope that I am audible to the audience. Great. So Judith, if you can start the presentations, that would be great. I mean, the PowerPoints, then I'll be talking it over. And before I start, as Michelle rightly said, I was very happy and privileged to be mentoring Judith as part of a Doctor of Nursing Practice program. And she visited us last year here in Ghana. And I'm very impressed with how far she has come. And so congratulations to you, Judith, once again. And today I'm very much excited to share a work that she did, which was a training program that was given to nurses on cognitive behavioral therapy for sickle cell disease pain management in Ghana. Yeah. Yes, as we know, sickle cell disease is a genetic disorder that results from a mutation in the beta globin gene. And this gene is the gene that is responsible for the protein hemoglobin, which is a major component of blood, and this helps to carry oxygen within the red blood cells to body organs. And it's also been shown that about 78% of the annual sickle cell disease births worldwide are in Africa, and Ghana is no exception to this. It's actually been shown also that about 2% of newborns in Ghana actually are born with sickle cell disease. And one of the major complaints of patients with sickle cell disease is severe pain as a result of the vaso-occlusive crisis that they get. And this is because then the red blood cells become sickled such that they occlude the blood flow within their vessels. And this is usually associated with severe pain. And as a result of this pain, sickle cell really has a toll on the quality of life of those living with the condition, because unless they've had a bone marrow transplant, it means that they are going to be living with the condition for the rest of their lives. And this means that they really have or do experience severe pain, which really affects their engagement with daily activities, which invariably also affects their quality of life and also that of their families, because then families have to support them in doing this. And as a result of the frequent crises that they do experience, that means that if they are not able to take control of their pain, then they are more likely to be visiting the hospital a lot of the time. And this also has implications on the stress or burnout that healthcare providers experience, of which nurses really play a key role in this. And so, as I earlier mentioned, about 2% of newborns in Ghana are diagnosed with the condition each year, and nearly 1/3 of them carries the sickle cell trait, meaning that they do not exhibit the full expression of it, but then they are they have the traits. Research also has shown that self-management among individuals with sickle cell disease in Ghana indicates that pain is commonly managed through a mixture of drugs and non-drug techniques, including heat therapy, increased fluid intake, massage, and also the use of strong topical creams on the painful areas, all in a bid to try and then reduce or manage the pain that they experience. Sickle cell disease management also heavily relies on drugs like opioids and NSAIDs, especially in Ghana. And it's been shown that nurses often lack the training in psychological pain management due to the limited support that they usually receive during their training and also after completion in this area. And nurses are also essential in delivering day-to-day care of these patients, as they usually serve as the first responders, and they also form majority of healthcare professionals in practice, and they are also well positioned to provide ongoing support for those living with sickle cell disease, and for that matter, experiencing pain. And so as a result of this, there is great potential for expanding their role through the cognitive behavioral therapy, so that if they empower their patients living with this condition, then they can be in control of their own pain that they experience as a result of their condition. And so in doing this work, we had to sort of look at what was in the literature, or what were the real reasons why we had to embark on this. We realized that there has been few studies that have been done in Ghana, and also in Ghana specifically, and that nurse-led cognitive behavioral therapy interventions have not been well studied also. And also bearing in mind that since most of the studies were done outside Africa, and also Ghana for that matter, existing models may not really fit the local context without adaptation. And this also meant that there's an opportunity for tax shifting to address the shortage of mental health professionals in Ghana. As you know, or for those who do not know, we have very few mental health professionals in this area. And so empowering nurses to take up this role means that we can increase the access that patients will have to cognitive behavioral therapy, and also integrate psychosocial support into existing care. Evidence from this study was also hoping that we will be able to inform policy and practice across similar settings. So in view of all the things that have been said, and in guiding this work with the model, as they said, that theory without, research without theory is blind. We were informed by the biopsychosocial model of pain, which looks at the fact that the experience of pain is influenced by several factors, which mainly lie on some biological factors, some psychological factors, and also some social factors. And I think this goes to emphasize that pain is really a multidimensional construct, and that is not always physical, and it's not always being judged by the amount of tissue injury that is happening, and that indeed emotions also play a very critical role, as well as other psychological and social factors. And so in looking at this, we felt that in doing the cognitive behavioral therapy for pain management. This would be a useful model as it really takes into consideration the multidimensional nature of this intervention. Yeah. And so cognitive behavioral therapy is also an intervention that has been shown to help individuals to really recognize and change unhelpful thoughts and behavior. It really aims at reducing pain and psychological distress whilst improving physical functioning and self-efficacy, as has been shown by earlier studies, and that the techniques used in cognitive behavioral therapy include cognitive restructuring, relaxation strategies, guided imagery, among many other techniques that may be deemed helpful. And CBT has been shown to improve pain outcomes in individuals with chronic conditions, including patients with sickle cell disease. And I think this is one of the things that has been the driving force to say that if indeed CBT is effective, then why don't we empower nurses so that they can also teach their patients to take charge of their pain using these techniques. And so in view of this, we hoped that we will conduct a cognitive behavioral training session for nurses who care for patients with sickle cell disease so as to improve their management of pain and also to be in control of how well they can manage or live their lives, even taking control of their pain and to help them to improve their quality of lives. And so I'll hand over to Judith so that she can tell us more about the study which she came to Ghana to do. So Judith, over to you.
Thank you so much, Dr. Abigail. So continuing on what Dr. Abigail explained, the objectives of the study was to assess the feasibility and acceptability of a one-time CBT educational training program for nurses in Ghana, and also to evaluate the frequency of CBT use for pain management among the nurses after the training sessions. So the question was, did they continue to teach their patients CBT techniques after the training session? And the project was conducted at the Komfo-Anyoke, or CATH, excuse me, Komfo-Anyoke Teaching Hospital, or CATH, in Kumasi, Ghana. And the original intention was for nurses who care for patients with sickle cell disease. And the intervention was that I taught CBT using and I taught 4 techniques specifically: deep breathing technique, positive coping statements, progressive muscle relaxation, and guided imagery. And there is no comparison because this is the first time this type of project has been done. And the outcome, we were to measure the feasibility and acceptability of uh, the study. So talking a little bit about CATH. CATH is a teaching hospital. It's in Kumasi. It hosts a capacity of 1,200 beds. And it's a center of training for postgraduate medical and dental practitioner, and also pharmacy, nursing, allied health allied health profession students. And it has 15 directorates, including anesthesia and intensive care, child health, emergency medicine, family medicine, internal medicine, gynecology, oncology, oral health, radiology, surgery, trauma, and orthopedic. And the hematology department that saw most patients with sickle cell disease was part of the internal medicine directorate. So the project had 3 phases. The first week was the week I arrived in Ghana. We had 2 sessions, and at that session in week 1, we talked about the project details and obtained consent from the nurses who came. We also obtained some demographic data, and then I conducted the CBT training. And after that, I had a satisfaction survey for them to rate the training and share what they thought could be improved upon. Then 3 weeks after that week or week one, 3 weeks after week 1 or week 4 was my first post-test evaluation. Also, it was
Standard diet.
in
And
person.
then the outcome we're talking about is reducing blood.
It was in person, and they had to fill out surveys, and they were reporting how many patients with sickle cell disease did they care for. Also, there was evidence-based practice survey and also feasibility survey. In addition, we also asked them some open-ended question about their experiences in teaching patients the CBT technique. I also want to mention that the nurses that came were not just nurses from the hematology department, because the sickle cell disease patient kind of go to different departments. So in the end, we had nurses who care for sickle cell disease patient from any part of the hospital. So it gave us more participants than we first anticipated. Then week 7 was a repeat of week 4. I conducted another evaluation week 7 to see if they were continuing to assess a little bit of the sustainability, if they were still continuing teaching the CBT to the patients, and what was the difference and what was the barriers to that. So talking about analysis and sustainability of the project, this is more of a multi-method study. And we had a qualitative analysis and a quantitative analysis part. So for the qualitative analysis, it was a descriptive study, and it was to analyze the content of nurses' report of their experience in teaching CBT to the patients. And for the quantitative analysis, to use non-parametric testing, use the Wilcoxon-signed rank testing of the EBP and feasibility surveys in week 4 and 7. And the short-term sustainability was assessed in week 7 via post-training evaluation, and also for future CBT refresher training. And my point was, which we had a group in WhatsApp with all the nurses that participated, and that was to keep in touch, inform them of location changes or anything like that. And since I came back, they have been asking for more another CBT training, because some of them were not able to make it, and others want to invite their friends from other hospital also to come. So we are talking about setting up a date for more CBT training. So for the result, talking a little bit about demographics. In week 1, the mean age of participants was around 35.84 years, with a standard deviation of 4.85. It was still the same in week 4. And we have a mean age of 35.70, standard deviation of 5 years. And week 7, we had slightly lower mean age of 33.75, with standard deviation of 3.33 years. I also want to show that in week 1, we had 52 participants. Week 4, we had 46 participants. In week 7, we had 8 participants. And we'll talk a little more about that. Talking also about the mean years of experience as a nurse, it's about 9.79 years for week 1, 9.74 years in week 4, and 3 years in week 7. Same for, not the same, but gender distribution. In week 1, we have mostly female participants. Same in week 4, and in week 7, that changed, that the majority was male. And talking about the different units that the nurses came from, the majority was from internal medicine. We also have some specifically from hematology and others from public health. And you will see that when we have results of the patients, when nurses talked about how many patients did they care for since the CBT training, some put 120 patients because they deal with a larger volume of patients in public health. And we asked if in week 1, if they have had any previous CBT training, and the majority was no, with 86.5%. Now, talking about the result analysis of the data, the objectives of the study, we were trying to see if this type of study was acceptable to nurses. And we asked them if they thought the CBT training was useful to clinical practice. And we have them answer with a Likert scale from 1 to 5. 1 was strongly disagree, and 5 was strongly agree. So the mean value was 4.22. So most of them thought that the training was useful to clinical practice. Some responses was that they felt that they learned non-pharmacological ways of managing pain. We asked them if they thought the training was a valuable use of time, and the mean value was 4.42. And some thought that it enlightens their knowledge about sickle cell. We asked if they thought it was a well-organized format, and the mean value was 4.13. And they say they like the preciseness of presentation. We asked if they would recommend this training to others, and we had a mean value of 4.33. And they recommend that we educate the community at large. A lot of responses mentioned that the training should be open to all nurses, whether they take care of patient with pain or not. Someone suggested that the training should be part of the orientation process at CAF, and others thought that we should open it and take it to other hospitals and also open it to the community and sickle cell patients. Now, talking about the evidence-based practice and feasibility of this study, we had EBP items, and I will go over them talking a little bit. I will mention the questions that we asked in a little bit. So we also had them ask, sorry, we also had them tell us whether specific question about if they thought the CBT was an evidence-based practice. And we had 7 questions, and they also could answer from a scale of 1 to 5, and with the same value, and the mean value was 33.18. So that's also pretty close to them saying that they thought that CBT was an evidence-based practice. Um, Same, but the value got lower in week 7, and we got a mean value of 25.88. So we were running, I first ran a t-test, but to adapt better to our um, population size in week 7, instead I ran a Wilkinson sign rank test that is more actual with the size that I got in week 7. So with the Wilkinson text sign rank result is that we have a z-value of minus 0.54 and a p-value of 0.785. Same questions for the feasibility, the mean value, and that was with 3 questions. So the maximum value would be 15, and the mean value was 13.02 in week 4, and the number goes lower in week 7. For the Wilkinson values, we have a z-value of minus 0.577, p-value of 0.564. And I also asked if they saw improved pain management and coping skills with CBT among their patients. And the majority of answers were yes. We have 93.5% who agree in week 4, and 75% who agree in week 7. So now talking a little bit about the most taught CBT techniques. And the majority of technique, the most taught was deep breathing therapy. They thought that it was easy to understand, easy to teach, and easy to apply at home. The other technique that was most taught was the guided imagery. That was 13% of respondents who taught guided imagery. Then after that is progressive muscle relaxation with 6%. Now, all the others techniques were that it was deep breathing with another type of technique. And that's what represent all the other bars or colors that you see. So deep breathing therapy was the most taught technique overall. Now, talking a little bit about self-report. The self-report was that I asked them how many patients did you teach CBT technique? So for week 4 participants, it was how many patients did you teach CBT technique since the training in week 1? And we had a lot of respondents who taught CBT technique. There was somebody who did not. I say somebody because it's very little. It's about 4.3%. And that was who did not teach anybody the CBT technique, but pretty much everybody else taught CBT technique to somebody. And even some people taught to the patient. And also, she taught her church members. She told me that there were a lot of people at her church that dealt with CBT. So she taught them deep breathing therapy and guided imagery, and they saw improvement. They came back to her and told her that they saw improvement. So now going to week 7, we have about half of people who did not teach anybody any CBT technique. So the question was, how many patients did you teach CBT since week 4? And then we see that there is a larger percentage that did not teach anybody CBT or any technique at all. So now talking about the results from the content analysis, CBT is acceptable to nurses because a lot of them say that they also saw improvement in their stress level and that they saw results with their patient when they taught them the CBT. One nurse told me she had a patient who came on the unit and was very agitated and was in pain, and the pain medication wasn't working. So she taught her guided imagery, and that she taught her the imagery, but the patient continued. So about 1 hour, she was able to report, the patient was able to report that she feel no more pain. And the patient was very thankful that the nurse gave her another tool to help with pain management, and that it was the first time she felt an improvement in all of her hospitalizations. That is the first time she saw an improvement in her pain level. So, but looking at the statistical analysis, we see the decrease in mean numbers from week 4 to week 7 for EBP implementation feasibility, and also based on the Wilkinson sign rank test result, that the associated p-value for those tests were higher than 0.05. So statistically, the project is not, the EBP and the feasibility is not statistically significant. Now, talking about some reason why we got those results. A nurse wrote that she thought or he thought the CBT to the patient, and the patient reported that the pain had decreased, but for just a short time. And then also in my responses, we had a lower amount of responses in week 7 compared to week 4, and also a change in the gender distribution, and also lower mean number of years of experience. So also the survey in week 7 was sent via email. So there could have been also lower motivation. Also that the percentage of nurses who didn't teach CBT to patients, it decreased. Excuse me, I should say it has increased, because in week 4, only 4.3 did not teach CBT, and in week 7, 50% did not teach CBT. So talking about the sustainability part, there might needs to be more efforts or more focus on keeping keeping refreshing CBT technique to the patient. So these could be reasons why we saw the results, or we did not see the same results from the qualitative analysis to the quantitative analysis. So consideration will be that future work should also involve patients. That's one thing that the nurses talked about, is that if we involve patients in the training, then those patients could be champions in encouraging other patients also to learn CBT. Some nurses were not successful in teaching CBT to their patients. They were not interested in it. Also, some future work should consider expanding CBT training to all nurses who work at CAP, and that was something that the nurses asked for because they felt that not only they are teaching pain management to their patients, but they are also learning about stress management for themselves and also pain management for themselves. So they felt that all nurses at the hospital should learn it. Also, I want to also mention about involving local stakeholders, including nurses or even other members of the healthcare team, in creating CBT training, also CBT educational pamphlets. They had access to the I call it a CBT pamphlet, but they mentioned that it wasn't it wasn't culturally congruent. So some future work would be to work with nurses or even patients in creating a pamphlet. They mentioned being able to have pictures that they can show their patients when they are teaching them CBT technique. Also, regarding sustainability, the future work should consider how to work on reducing the attrition rate and ensure continued motivation in learning about CBT technique. So this is the conclusion, is that educating nurses in CBT for pain management is a first of its kind project, and it has a lot of promise. And the nurses express benefits from using CBT themselves. One nurse approached me and she said that doing a deep breathing technique and guided imagery, she saw her level of anxiety being reduced, and how she approaches problem in her own personal life, that it has improved significantly. So she was very um, thankful for having learned CBT. And I told them during the training that and I was encouraging them to practice after they leave, that when they practice, they have a better understanding and that they see the results themselves, then they can teach others. So having one nurse express that was it was a good point for me. And also, they reported that patients express satisfaction in having one more tool to combat pain. And also that there is more opportunity for more research in this area. And I will stop shelf quickly. And I want to also show um, I want to show the results, some of the results, and show the questions that we have asked them to answer during uh, the evaluation. And I'll go back and share my screen again. Yes, this one. Okay, share. Okay, so here are the results, and I have the link in Google Drive link, and I can share in the chat, and you can take a quick look at it. And these are the self-report results for week 4 and then week 7. Now, for the EBP analysis, they were to um, rate or the agreement to the questions. The questions, the first one was, or the statement was, I have used CBT to change my clinical practice. And we can see that in week 4, majority rated a 5, so they agree to that statement. And week 7, we had about 50% that agree with that statement. In the EB2, the second statement was, I am sure I can demonstrate a CBT technique. And that was 60.9% in week 4 and 37.5% in week 7. So there was a decrease in that level of confidence. Statement 3 was, I am sure that CBT can improve clinical care. And most agree with 47.8 in week 4 and 25% agree with that statement in week 7. Still, strongly agree in week 4 is 45.7. and strongly agree is week 7 in 50%. Statement 4 was I can overcome barriers in demonstrating one or more CBT technique. And it was a strongly agree with 41.4 in week 4. And there is none that agree with that, strongly agree with that statement, but they still agree with 87.5 in week 7. And I will just run quickly through the rest. Statement 5 was, I am sure that I can implement a CBT technique in a time-efficient way. 50% agree with that statement in week 4, 37.5 agree with that statement in week 7. And statement 6 was, I've shared demonstrated CBT with a patient and or family member. So strongly agree was 52.2 in week 4, 12.5 in week 7. So, and statement 7, I've shared demonstrated CBT with a multidisciplinary team member. 28.3 agree in week 4, and 75% agree in week 7. So we can see kind of the progression in the frequency of CBT teaching to patients, CBT teaching to other team members. So talking about the feasibility survey, the first statement was, I have shared or demonstrated one or more CBT technique to a patient family member. And 43.5% strongly agree compared to 12.5% in week 7. And I feel comfortable teaching one or more CBT skills to patient and family members. And 58.7 strongly agree week 4, 25% strongly agree week 7. And last one for feasibility, the statement was SCD patients are receptive to the CBT technique I taught. And 52.2 agree in week 4 and 37.5 agree in week 7. And those were the numbers I used to run the Wilkinson sign rank test. And I also asked, do you believe that using CBT technique has contributed to improve pain management and coping skill? Well, 93.5% said yes in week 4 and 75% said yes in week 7. And I also have some qualitative respondents response. So even though the analysis don't show that the study, quote unquote, was a success, from patients' response and nurses' response, they really enjoy and they saw improvement in not just their pain level, but also overall their quality of life. And I will give the mic back to you, Michelle. Thank you.
Thank you, Judith and Abigail, for a wonderful presentation. It's fun for me to see how this project has evolved over the last couple of years as well, which is very exciting. So we appreciate both of you joining us this morning. We do have some time for questions and conversation. So we have a relatively small group. You can feel free to use the chat, or you can also unmute if you have questions as well. Megan, I see you're unmuted, and I wasn't sure if you were just clapping or if you do have a question.
Just by accident, but
Okay.
congratulations, very nicely done. What I was wondering is, as you think about how to sustain the impact that was clearly there at the beginning, what ways in context can you think of that might help motivate nurses to continue to use it? There's, yeah. Have you put some thought into what might help essentially the treatment effect, right? The effect of the intervention, what might help sustain it or give small doses to keep it going?
I think the main point to help with sustainability will be to continue training nurses in CBT. I have a WhatsApp group, and I need to transfer it to the US number, but I had put in all the nurses that signed up. Not all of them could make it. So they had asked me to have another training for everybody, and some were also gonna join who wanted a refresher. So from then on, if we can, or I can continue to teach regularly, because that's one thing they mentioned, have refresher courses as well. If you can continue to regularly teach, that will be a great a great impact. Also for the study, they will ask me if they could bring their friends from other hospitals, and I say no. My study was very specific, but with this WhatsApp group, I'll be able to include anybody, anyone, anywhere. So whether it be patient, it be nurses, no nurses, anybody could be part of it. So I think that will help sustain the momentum. And then I also connected with a lady who helps a support group with adolescents with sickle cell disease, and involving the patient sides also is going to be a great positive aspect. So that's that. Abigail, you can go ahead.
Yes, thank you very much, Megan, for the question. Just to add up to what Judith has said, for nurses in Ghana, on a yearly basis, they need to take some courses so that they can renew their professional identity numbers, which we call the PINs. And as part of the requirements, they need to undertake some form of continuous professional development programs. And so I'm thinking that perhaps we could look at how we can sort of set this as an annual training or something that the nurses could take, and then they can get credits to renew their PINs. I think that may be something that would be useful. Of course, the literature has also shown that there are a number of techniques that we can do if we want to sort of get some form of sustainability. And this usually happens when there's sort of some metric whereby if they do that, they get some additional points for their promotions, or maybe some constant reminder, even in the form of maybe posters on the walls or something that could really serve as a constant reminder. I think we can also explore using those techniques to see if that is something that can sort of enhance sustainability. And I think the real driving force also for this to say that if we can empower our patients to do this so that that reduces the workload on us, then that could really be a good motivation for people to get into this. Yeah. Thank you.
Thank you.
Abigail and Judith, I actually have a question I wrote down as well. So Abigail, when you started us off, you were talking a little about task shifting and that there are not a lot of trained mental health professionals, right, to provide support. And so I was thinking a little more just about sickle cell and how uncontrolled pain really could be linked to, anxiety, depression, especially in adolescents who are already kind of potentially having more mental health concerns as well. And so I'm wondering if you've thought at all about that and looking at some of the mental health outcomes as well. I know this was really focused on the nurses, right? And so kind of how they thought they were doing teaching the different techniques to patients, but potentially looking at patients and some of the different mental health outcomes to see if there's an influence not only on pain management, but just their overall well-being as well.
Thank you very much, Michelle, for that question. And I think that you are truly spot on with that. And as we say, just educating nurses is not an end in itself. I think it's just a means to an end. And the real goal is really how we can get this to the end user, which is the patients who are living with this condition. And I think that in future, we can explore how this impacts on them, like I earlier said, to really see whether indeed the education that we are given is really translating to the changes that we hope to see. So I think that that is something that we can look at also in the future, hopefully with some future BMP students also taking this up. So Ghana is a good place. Maybe let me use this opportunity, and I'm sure for those who want like further perspectives on this, you can contact Judith and Esther, who have had their experience here. And I must say that this is something that is really close to my heart, because I think that pain is unbearable, even for normal people, and much more so for people who, by no fault of them, they happen to live with a condition that we really do not have the facilities for bone marrow transplant and all of that. And so it really means that people have to live coping with this. And I'm sure we can all imagine how it feels like living with constant pain all the time. And I think we may say that people can take drugs, but as we know, drugs also have their side effects. And so if there are any efforts that we can use to make sure that the amount of drugs that people consume are limited, which invariably means that we are also limiting the amount of side effects that they would experience, then it means that really interventions that are non-drug in nature and are also associated with limited side effects are really the go-to. And it's also said that it's easy to do and it's something that they can be in control themselves. Then I think that it's really a step in the right direction for us to look at. So we are really looking forward. I think there are many areas that hasn't been explored, and we are open to sort of helping with knowledge generation in this field. Thank you.
Thank you, Abigail. There are a couple of questions in the chat. Judith, I see you started to answer one, but maybe we can just do that out loud. So the first one was from Giselle. What are the facilitators and barriers to the sustainability of using CBT? And Judith, I think you wrote a little bit about this in the chat if you want to share.
Okay, so the facilitators were that the nurses had a high enthusiasm in the beginning after they learned the technique, because they say that it helped them learn, have another tool in their pocket, and also that it was something new that they learned. They learned a little more about HCD. There was my recruiter, the lady who helped me recruit, was really intentional in encouraging people to come. So they came with high expectation and they were very excited about the training. So I would say that was a facilitator. So the techniques itself and how can we help our patient with sickle cell disease, how to help empower patient. Some barriers was that we had some technical difficulties, and also they mentioned that because I was the one who conducted the training and I talked about CBT, and we did a group demonstration on the techniques together, and they mentioned that there was a little bit of a accent problem. And also that I had given them a pamphlet about each technique and how to apply it. They felt though that it would be difficult to use that with the patient, that having just like a picture booklet that they can just easily pull out and just show the patient would have been better. So I would say the materials presented, and then also then later on there wasn't as much motivation in answering the survey. So I would say they decreased motivation in so that would be the matter of keeping people interested and sending reminders often to take these surveys. That's what I saw.
Judith, one of the things I think about with the pictures, and I saw Renee on here, I'm not sure, I know she's driving, but is HBLSS, so home-based life-saving skills, uses kind of a picture-based educational, and so I'm just thinking, I know that a few of our faculty and students have used that for education, more around like maternal health things, but that could be something really cool where you have the pictures, right, of the different CBT techniques and almost like a story or a case on how to use those. And that actually leads to the next question. So Sunwa, I think, asked what specific CBT techniques you taught the nurses.
So I taught them a deep breathing therapy, deep breathing technique, positive coping statement, guided imagery, and progressive muscle relaxation. So I I had two sessions, one on Thursday, one on Friday. And from Thursday, I learned that, because I could hear some comments, was that they will have also like to have a video. So on Friday, I showed them a video and then we practiced together. But those were the techniques I taught.
Okay, can can I share a little bit about the program? It's okay.
Yes,
The program.
go ahead, Oh.
Okay. Yes, thank you for your presentation. And I think sometime I know is my the program might be interfered by many factor that is maybe it's not significant at the beginning, but I would like to share it's like I have the experience to train a nurse in a hospital in Thailand, and we know that we about the pain management. Sometimes we need to give the attitude or educational for the nurse to be maybe it's like a to awareness about the pain management first sometime, and then for the CBT technique that you use is sometime I think I'm not sure about the how many dose of intervention that you teach of the group of the nurse, and then maybe it's it's one time is sometimes it's quite uh, a short time, a period of time for them to learn more. Maybe you can mix with maybe in practice and maybe online course or something like this. And then I think is the important thing is like how about the cultural factor that impact for the attitudes of the nurse to use this technique. Can you share with me a bit about this?
Yeah.
Very concerned about it.
Okay, thank you so much. I will go back a little bit talking about the intervention. So we had those two main sessions, and they came back in week 4. I had a group with them in WhatsApp. So I was sharing with them the videos that I've used on Friday. And also, if they have any question, they could come. So I also made available to them the PowerPoint that I used during my intervention, and also had a recording of that PowerPoint, so they could always refer to it if they needed to do a refresher. Because like you say, that's one thing they say that, oh, this needs to be done regularly. They wanted it regularly at specific times. So the idea was that also that after I came back, which I've been on my foot on lacking on that, we're going to set up another time of CBT training. So we're going to have more CBT trainings with them and then other people that they want to invite. Now, talking about the cultural factor, so my understanding is, first of all, my interest in CBT was with deep breathing therapy. And that was at a time when COVID came, and I saw my level of anxiety go really, 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 really high. So, and I started, I had found an app that guides you through breathing techniques. So I got to see the effect myself. And I was explaining to them, if I had not had that experience, somebody was to tell me about CBT, I'll just, like ignore you. So really coming from a place of understanding of experience, if you have experienced it first, then you can explain more about it. And also explain to them it is something new. It is not a tangible technique, just like, pain management or anything tangible that we do. But I explained that the brain processes pain. It's not just from a biomedical, just you are hurt and you having pain. There is more that goes into it. Dr. Abigail talked about it, that you have some cognitive, emotional, and social factors involved in it. And all those factors impact how pain is processed. So if you just stick to one model, then you missing the other points, and you're not treating pain accordingly. I also pointed out that we having limitation with pain medication because now there is an opioid crisis. I hear that's everywhere now. So we need to give patients more tools. And it's not to take away the opioid, not to take their pain medication, is to add something to their toolbox so that they don't need the pain medication as much. And explaining also that the more they practice, the more the patient practice, the more their level of pain tolerability increases. So those were the things I explained. And I also said we have different techniques. If there's a technique that you don't feel comfortable with, you can also use other techniques. So most felt comfortable with the deep breathing because we are breathing, but they had to breathe from their belly now. They have to really bring in oxygen. Some felt comfortable with guided imagery. and some felt comfortable with the progressive muscle relaxation. So giving all those points kind of for them to understand, I say the brain is a very complex organ and we are still, trying to learn about it. There's still a lot of things we don't know. But the goal is again to empower the patient, give them more tools to use in pain management. So that seemed to really help them understand, it's not some kind of weird things that we are doing. No, this is some techniques that have been proven and shown to help. And if you try yourself, you will see it. And a lot of them, when they practice at home, they told me, yes, they felt the difference themselves. I don't know if Dr. Abigail wants to add to what I just said.
Oh, Judith, I think you have said it all, so I wouldn't want to bore us with any more talks, but I'm happy to take any more clarities that you need. Thank you.
Ibrahim, do you have, I think we have time for one more question. You can go ahead, Ibrahim.
Thank you very much for this presentation. Prof, I think I have an additional therapy. I think if they incorporate it in it, it will give more therapy to relieve the pain from the patients. Therapeutic touch. For that model, some people are there due to excessive pain and what the people are doing to them in the house. They don't get that kind of care. But if you are caring for patient with severe pain and you tie the patient therapeutical whilst you are attending or conversing with the patient and you tie the patient, at least you psyche the mind that this person actually care for me. What I am going through, the person feel it much. So I think if they incorporate it, it will help. That is the addition I have. Thank you very much.
Thank you for the suggestion. Thank you.
All right. I see a few more comments in the chat. Really just again thanking you both for your time and expertise and answering the questions and sharing everything. So I think this brings our conversation to a close. Thank you so much, Judith and Abigail, for joining us, for sharing your work and for the work that you do. Thank you to everybody for attending our 2025 Coffee and Conversation series. This is something that we do annually. It generally starts after our Global Health Summer Institute. So if you're interested in joining us in the future, I know Jen put in some information on how to follow us on LinkedIn. And we post our flyer and sign up for these events, usually starting in the springtime, as well as at our Global Health Summer Institute. Additionally, if you have suggestions for either topics or speakers, please reach out to me. We're always looking to hear from new colleagues about different topics that our audience is interested in. So thank you again, Judith and Abigail. We really appreciate your time. Abigail, it was great to see you. It's been a little while. And I hope everybody has a wonderful day.
Thank you very much.